Okay, so I think we're all good as far as recording's concerned. Thanks very much for being here, everyone. My name's Kieran Lewis. My pronouns are he, him, and I'm NSUN's policy officer. And yeah, really excited to welcome you today to what should be a really interesting and very important discussion of surveillance and invasive data practices in mental health care and what these practices mean for survivors and service users. Perhaps most importantly of all, we hope that this discussion will also serve as a starting point for thinking about how we as individuals and groups with lived experience of mental ill health, distress and trauma might be able to stay on top of and push back against some of the disturbing developments that we're seeing in surveillance on psychiatric wards and beyond. And we've got three brilliant panelists who've kindly agreed to help us to think through some of these questions today. I'll allow them to introduce themselves, starting with Hill, if that's okay.
Thanks, Kieran. Hi, everyone. Really good to be here today. My name is Hill Akid. My pronouns are they, them. I'm the Research and Policy Manager at MedAct, which is a member-led health workers organization. We work on social determinants of health, so political, economic, and social factors shaping our health, everything from climate change to fair pay to the prevent policy and housing. And I'll speak a little bit today about our Patients Not Passports campaign and the data sharing practices we see there, but more specifically in mental health, a project called Criminalising Distress, which looks at SIM and other similar practices, and also something called the Vulnerability Support Hubs, which is an arm of the prevent policy that specifically looks at mental health. And I'll pass to Hat.
Hi, yeah, my name's Hat. My pronouns are they, them. I'm here as a member of a campaign group called Stop Oxevision, which is a group of mental health service user survivors challenging surveillance practices in mental health inpatient settings. So that includes specifically a piece of technology called Oxevision, which is a camera and infrared sensor that is used in mental health inpatient bedrooms. So it takes a patient's pulse and breathing rates, but also does allow staff to observe the person remotely through the camera. So as a group, we're challenging, raising our concerns around the use of this particular technology, but also within a wider context of surveillance in mental health settings generally. So that also includes things like body-worn cameras and CCTV use. Yeah.
Great. Thanks very much. Alison, would you like to introduce yourself?
Yeah, hi, I'm Alison, and I'm a survivor researcher. I have personal experience as both a survivor, as using mental health services, but also as a researcher for something like 30 years. And I look back at my extensive history here, and the very first piece of work, research that I was involved in, we looked at Section 136 of the Mental Health Act, in which the police can pick people up. And so I guess I've got a long history of thinking about the criminalisation of distress. But also most recently, I've done some work, and I see that Rachel Rowan Olive was here in the room, I think. Yeah, I see her. We did a bit of work, survey. I'm analysing another one now for self-injury support. So my particular angle, if you like, I'm partly quite interested in. No, I'm not interested. What am I talking about? I'm fucking angry about the way in which people who self-harm and attempt suicide are sometimes given ASBOs and are punished for doing things in distress. And I I know I'm perfectly capable of talking in a very polite and very professional fashion, a middle class accent, but I think we need to be really, really angry about what's going on for people right now in services. And yeah, I mean, I was given the opportunity as a researcher to take part in research on body-worn cameras. I'll say a bit more about that later, but we have to make decisions sometimes about whether to get involved in things. And yeah, that's another theme I'll talk about later. But yeah, let's be angry, everybody.
Yeah, thanks very much, everyone. And yeah, couldn't agree more. We definitely, that there is unfortunately quite a lot to be angry about, as we will get into. So yeah, I think something that's really apparent is sort of the range of experience and perspectives that we've got across the panel today. So I thought that we could start by sort of asking each of the panelists to talk us through the concerns that you each have around surveillance or invasive data practices in the particular area that you work or campaign in. So, Hat, would you be okay to kick us off with that?
Yeah. Okay, so basically I explained a little bit about what Oxevision is, but to like just expand a bit on kind of our concerns about the technology. So firstly, we kind of consider this technology to be surveillance, and because of that it is an example of restrictive practice. It tends to be used, and as we found through freedom of information requests, trusts are not using it with patients' consent. Often it's being used without people's knowledge. So patients don't even know that the equipment in the room is a camera. Oftentimes this is because they aren't given clear information. So other phrases are used, things like secure optical sensor or things like that, where it kind of isn't clear that it's a camera. It isn't clear that people's the recorded footage is then saved, that staff can view that. So because of that, patients don't necessarily even know that they're being kind of recorded, which is really, really concerning. The kind of the big concern around that is in terms of like the impact that it has on people's privacy and dignity. We know again from speaking with patients who've had this technology used, or also from some of the information, the research that we've done, or freedom of information requests and things, that people are able to be kind of seen in their rooms. They are kind of afraid of kind of the technology because of they don't know kind of when they're being observed, who they're being observed by, how that information is then used, as well as the staff on the ward being able to look at the video footage of patients in their rooms. Some of this footage is also accessible by the private company who make the technology, and they kind of use this as part of building and developing their kind of product and their algorithms, which then enables them to kind of go to other countries or other service types to kind of further try to sell the product. And obviously they're a for-profit private company. So we're kind of particularly concerned about the ethical implications of people's video, like sensitive footage of patients being in the handling of that. We also know that the way the technology works is that video footage of patients is kind of stored for 24 hours as standard. But also in some cases, if there has been like an incident or something, staff are able to clip and save certain sections of the footage. So that enables them to kind of use the the video footage as part of like prosecution or kind of criminalisation following like a particular incident. So as part of that, we're kind of concerned about the implications it has for furthering kind of criminalisation of distress and people when they're really unwell, as Hill and Alison will probably speak a bit more about as well. And then, yeah, I don't know if I'm kind of passed to someone else, but can obviously explain a bit more. And
Yeah. Oh no, thank you very much for that was such a helpful rundown of kind of Oxevision and some of the main concerns around it. That's much appreciated. Hill, would you like to take us through some of the main concerns in the main sort of areas that you work in campaign in?
Yeah, absolutely. So yeah, I'll talk about the three kind of areas, campaign issues that I mentioned. Firstly, the patient stop passport work that MEDAC does is within our human rights strand of work. It's particularly focused on fighting the hostile environment in healthcare, and particularly around the issue of charging for people of certain immigration status. And from a charging point of view, the data sharing is the same for mental health as at any other areas. So what I'm saying now is not specific to mental health, but it includes it. So essentially, the main harmful practice that we see here is, or one of the key ones, is the reporting of debt data. So NHS Trust will share the names, addresses, like NHS numbers of people who have a debt of £500 or more for 2 months or more with the Home Office. And the Home Office can and do use it to find and deport people from Britain. We know that the NHS shares patient information, sometimes also in the process of identifying who is chargeable. And so that Home Office database is connected to the NHS spine, and it assigns different status to different people. It's a bit of a black box as to how the algorithm works, but there's good reason to be suspicious that it's fundamentally operating on a kind of racist basis. And what this means, the implication of this is that like Home Office data about immigration status influences the provision of public services to certain groups of people in an unaccountable way. Kind of to the side of that, but related, there's also like ad hoc examples of people within mental health and other health spaces being kind of racist on a more ad hoc basis. So GP receptionists or staff might have been known to call the Home Office on people they believe may be undocumented. So there's this, unfortunately, this real culture of, surveillance has been inculcated within health spaces, and it fits a wider pattern of like drive towards like integrated partnership, multi-agency working, and the porous barrier between various bits of the public sector, which in some ways can be positive. And there's, this is the argument we always hear that, more information sharing is good. But when it comes to sort of health data being given to police, we obviously I'm very concerned about that. But it happens, all the time in non-mental health spaces. For example, police asking, A&E staff to hand over people who've come in with knife wounds or something, and that A&E staff very often will just hand it over. And MEDAC's kind of work around during the COVID-19 pandemic with people with insecure immigration status showed that like what that leads to is people don't trust the NHS, don't go and seek healthcare, and that obviously worsens health inequalities. And I guess it's probably worth noting that maybe we'll talk about this later, that this is only going to get worse, this issue of trust, when there was news the other day that Palantir, the US data analytics firm, has been given this massive, I think it's 480 million contract for the federated data platform. and that is going to just, yeah, as I say, worsen the trust issues, I think. To mention very briefly, I can't say loads on the criminalising distress work because we're still analysing the findings, but Stop Sim, many of you will know, campaigned against Sim, or Serenity Integrating Mentoring, really doing incredible work to expose it and to help put pressure on, to create pressure on NHS England to kind of eventually say that it shouldn't be happening. So the Criminalising Distress Project, which we're lucky enough to have former members of the Stop Sim Coalition on our steering committee to help guide that work, looks at the data sharing practices there. Essentially, like as Stop Sim showed from the start, what that enables that project, and we don't think it has fully ended, or that there may be like other very similar practices going on even under different names, is that, again, health data being shared with police very readily, very sensitive health data. And what our interview data shows is that in many cases when SIM was being rolled out, or at least in some cases, information governance people whose job that is were raising concerns, but they were not heeded within the trusts. And just finally, a quick mention I mentioned vulnerability support hubs. So they're quite like a secretive project that within the prevent space, which is one arm of the government's counter-terrorism policy, focusing on extremism. And it's again a police-led project, but specifically looking at people who are reported to prevent as potential extremists, or quote-unquote extremists, who may also have like what's deemed to be a potential mental health issue. Overwhelmingly, these people are racialized Muslims, and essentially what the hubs do, and they're based in like counter-terrorism units, but they are NHS workers embedded like in-house within counter-terrorism police. So again, police have explicitly, we have a report on this from a couple of years ago, police praise those hubs for allowing them easier access to health information, because in some spaces it's still there's a reasonable respect for confidentiality norms, but with what they do with these in-house health workers, when they request health data from other colleagues in health, it's not understood because people haven't heard of these hubs, like how easily that is then going to get into the hands of police. So it's a sort of a bit of a backdoor way of gathering. And also, you know, we're very concerned about the hubs because they explicitly use words like monitoring to describe the role that health workers should be playing, and very much blur the boundaries between like the criminalizing and punitive functions of the police and you know, what should be the function of health care workers, which is care. So I'll leave it there.
Thanks very much. I really appreciate that. And yeah, some really important things to think about, like, yeah, the sort of drawing of healthcare workers into policing and sort of the policing of the border as well. And also appreciate you speaking a bit about the criminalisation of distress work, even though it's not quite finished. So thank you for that. Alison, would you like to talk us through some of your main concerns around this in the area that you work in?
Yeah, so I guess just picking up on what Hill finished with really there, which is about the criminalisation. And I think the police have always been involved in mental health, let's be honest. And also mental health services have always had a very, you know, there's always been a tension about their role in society because they are policing normality, basically. Mental health services are policing what we think or what society has decided is normal and what is not normal. So there's a real sort of overlap, crossover there anyway between the police and mental health services. And as I said earlier in my introduction, my first involvement in mental health research, I worked for Mind, looking at Section 136 of the Mental Health Act. And, you know, my first learning in that would be in my 30s, I guess, was about how that method, the police are, you know, picking up more Black people than they are white people. You know, so first of all, you're looking at some of the surveillance and policing sort of measures. These surveillance measures are often targeted at groups that are already marginalized, and as Hill was already saying, people who are also on the edges of, the society that we would like to think of as a great deal more caring and inclusive than it obviously is. But I do think that all of the measures that we've been mentioning already today, so body-worn cameras and SIM, which incidentally absolutely horrified me. I mean, some of these things really do, horrify me. The surveillance of cameras when you're alone in your room on the ward. What do we mean by safety? I think we have to think very much more. I know there's a question. One of the questions we're going to be asked is about what would we like, what might safer practices look like. I just think we need to think so much more about what safety means for people. If you're in an acute ward, does it feel safe to know that somebody's watching you? Does it feel safe to know that a nurse can turn their body-worn camera on when they choose to? And I think my real objection to body-worn cameras was, to all of these things, but those in particular, because the nurse has the choice when to turn it on. Or would you have it on all the time? But I don't think you would. So the predisposing factors that might have contributed to an episode of self-harm or violence but made the nurse turn the camera on are not picked up. So you don't know what role that nurse might have played in what happened at that point. I'm really, really interested in how do we help people feel safe. And I know through the work that I've done, the research that I've been doing with self-injury support, that many people who self-injure on a regular basis or attempt suicide from time to time because of their distress and the situations that they're in are avoiding services because they are too anxious, paranoid. I use paranoid in the broadest sense with a small p, not as a diagnosis, but the anxiety people have about being in touch with services, the lack of trust particularly for Black people and people of colour of this whole system, the whole services. These measures are adding to that. So I feel there is an issue here of equality needs examining. What is that? There is that sort of official measure that you can do, isn't there, to explore whether something has disproportionate impact on people who are already disadvantaged, marginalized. So I don't know whether that would be, I mean, I've just been reading, actually, reminding myself of where Akiko has been to liberty. My human rights. I would like to see a campaign to look at, torture and suffer. I must not be tortured or suffer inhuman or degrading treatment. I just think that many people in mental health services, I really don't want to totally trash the whole system, although I feel tempted to do that, but I feel that many people suffer inhuman and degrading treatment in mental health services, and people do not feel safe. How then are we going to help people on their journey to, recovery if we're surveilling them, if we are, preparing to take, to film them at times when they are at their most distressed? Oftentimes, I mean, I have been threatened with seclusion on one occasion, and I didn't feel that I could approach staff for help when this male patient was following me around. So I took my own sort of measures that were not acceptable, obviously, in that environment. And I mean, you are driven to it. I'm not a violent person. I'm also only 5 foot tall and extremely small. Nobody's going to be very scared of me. But, the fact is that some situations drive us to, extreme measures because we are scared. We are in deep distress. And how do we feel safe? How are we? I want a service that helps people feel safe. Anyway, that's
thanks very much for that, Alison. I really appreciate your contribution there and what you shared. And you alluded to the direction that I'd like to take this in next. Quite conscious that this is quite a big can of worms that I'm about to open, and we are now halfway through. But I think it's really important in these discussions to sort of, as much as we are dealing with a lot of quite disturbing developments on all of these fronts that you've just mentioned, it's important to leave room for imagining what alternatives might look like. And that's why the next question that I'd like to put to all of you is, what might safer data practices look like in these areas? What is it that we'd like to see? What are the changes that would help us get there? Very big questions, I know, but Hat, would you like to have a go at those first?
Yeah, yeah, no, it's a good question. And yeah, I think everything Alison and Hill that you were saying, I think really resonates with my feelings and my experiences, and both like as being a patient and also in the campaign work I've been involved in. I think one of the things about these around surveillance and cameras and things that we've heard quite often is people sort of wondering whether the presence of the camera would protect patients in instances where staff are abusive towards patients. And I think there's kind of, some merit in that, thinking that, if you can kind of use the CCTV footage to show what's happened, that might be protective and kind of support the safety of patients. But I think, like, exactly as you're saying, Alison, was the staff have control of what is filmed, what is saved. It means that it is completely kind of out of control of patients, so you're not able to kind of know or even say kind of what you want to be saved. And we've heard from people as well that when they've requested footage, it's been, oh well, it gets deleted after 24 hours, or oh, the cameras weren't actually working, that kind of thing. And yeah, I think obviously that is really concerning. I think often where things like surveillance are used, they're kind of positioned as like a solution to a problem in mental health services, but it's based on like the system not working. And so for example, I think one of the kind of ways that Oxevision is marketed as being a kind of solution to inadequate, unsafe levels of staffing. And so one of the kind of ways that it's kind of tried to be promoted as a solution, when really what patients need most is to have that level of like quality therapeutic relational like support from staff as well. So kind of replacing that with more technology and kind of seeing that as the solution, rather than actually addressing the real issues with underfunded, understaffed, but also like health services, which, like, as you were saying so clearly, Alison, like really like breach people's human rights, and where people face real like abuse, discrimination, real harms. And I think like adding more technology or more innovations and all of these solutions without actually addressing the underlying issues and all of the drivers which kind of continue to allow mental health services to harm patients as much as they do, it means that the technology only becomes kind of part of that harm. It's like yet another tool that can be used against us, used to abuse us, used to oppress us, kind of thing. Sorry, my brain's a bit all over the place today. I'm not really like explaining exactly. But yeah, I think my sense is that the alternatives are kind of actually addressing the systemic issues rather than kind of piling in more technology to line the pockets of private companies.
No, thank you very much. I think that was really clearly explained. So thank you. Hill, would you like to have a go next? Yeah, talking us through sort of what you might like to see.
Yeah, sure. So I guess I could sum up what I'm going to say is just stop it. But like, yeah, I mean, I don't want that to be glib, but like with regard to the Patients Not Passports campaign, that what the main call is for a firewall between NHS data and the Home Office, so no more sharing basically. And that's it. But also what they try to do is to engage health worker staff on as to how that data sharing impacts people, and there've been some really there's been some like advocacy casework and campaigns that have been really inspiring, and there are ways in which obviously we're seeking structural change at like the level of like national legislation, but also like encouraging health workers to like undermine and resist the calls to share data at the grass, like in their everyday lives. Yeah, in relation to like projects like SIM, I mean, it was very clear from like the complete lack of evidence for it, and as well as the like clear harms that it caused, that like this was never like properly evaluated at all. And one of the main things that's coming through from the project we're doing into it is that which Stop SIM emphasized as well, is that it's not an aberration, it's like a symptom of lots of different wider problems, the criminalisation that Alison was talking about, the neoliberalism and the kind of drives to save resources and under resources under resourcing, as Hat said, but also the kind of like urge to like share data more widely. So like basic things like data protection impact analyses never, very, very rarely happened anyway. And so I think, it's quite basic, but like restoring a culture of like actual consent for data sharing, for us, that's important as a kind of health worker led organization. And because it's been massively eroded by loads of different schemes. Prevent is a big one. The charging that I mentioned, migrant charging, and SIM as well. And there's a particular, with things like Prevent and migrant charging, there's a particular kind of racial exceptionalism where it's people of color, Muslims, people racialized as Muslim are kind of being not their consent, their right to consent, or otherwise to refuse consent to have their data shared is particularly like disrespected and undermined. But it's being eroded across the board. So we're in relation to Prevent, we want it to be we've called for it to end in the health sphere and beyond, and we want the vulnerability support hubs to be closed down. And then I guess I noticed that Just Treatment, who are another kind of like health NGO, had a report out yesterday where they made 4 calls. Actually, one was for more co-design with patients to replace the national data opt-out. A second was to revise the procurement process for health data services. A third was to give local communities more of a say over things like the federated data platform. And the fourth was to tighten controls around like different apps. I mean, I totally agree with what Hat was saying about like technology is this quick fix myth that we get sold, but when they are useful, I suppose that's they all seem like good, important measures as well to me.
Thank you very much, Hill. Alison, would you like to have a go at this quite difficult question?
As I mentioned earlier, I'm really concerned about how people can can feel safe when they're within services, and I think that's not something that's happening very much at the moment. And I'm not saying it doesn't happen anywhere, but I think for me, I mean, that's what's really important. How what helps people to feel safe when they're in on an acute ward. You know, that whole thing is just, I think it's now really being completely neglected, because I feel as though the direction in which services are, in which these kind of measures are indicating services are going in, and it may well be that there is a lack of resources. You know, everything can be blamed on a lack of resources, but what happened to compassion and understanding? One of the things that concerns me around self-harm and suicidal suicide attempts and so forth, that kind of area of my interest, is that there is, I think, an underlying belief that people could just stop doing it if they wanted to. That there is an agency, and I'm not talking about capacity here. I'm not talking about mental capacity. I'm talking about this assumption by staff, not just the general public, by staff in services, that if you just pulled yourself together, you could stop self-harming. You know, it's something you've chosen to do, and you've decided to do it. So, and I think we need to have a great deal more. I mean, I talk about understanding, and Rachel has challenged me, Rachel Rowan Olive, who I did the work with, has challenged me a little bit on that, to say, you know, maybe it's too much to expect people to understand about self-harm. Maybe what we just need to do is reintroduce compassion into the service and just say, like, you know, we understand that you are in distress. I don't understand self-harm, but I will be compassionate about it, rather than adding punishment on top of self-punishment. And I think that services have so gone in the wrong direction with regard to that particular area of distress. But I'm not saying that's the only concern at all. Because I mean, the other concern I have is that people imagine these measures are creating some level of security or safety that they are not. It's a mask. It's not real. The only study that I read in great detail about body-worn cameras, for example, I think I'm still talking about problems when I should be talking about safety and what are the alternatives. So just stopping myself now. More real, genuine, authentic peer support, I think, would be a really good way to go if we knew good ways of implementing it within services. And I'm not sure always we do know that. Ironically, one of the best examples of a ward I found was a forensic unit for women. And they had a safe room, a room with really, really nice sort of things in it, that was created as a sort of sanctuary. And maybe that's something that would help an individual ward. And again, you know, you've got to make the space for it. But I mean, bloody hell, we've got masses of buildings. I can't believe it's not possible. I just really feel that we've lost, that mental health services have lost direction, that we need to refocus the whole direction of services back towards care and compassion. And, you know, I just think that these measures it's technology. It gives people a sense of security. Oh, look, we can watch them, so we will know. But that isn't true. It really isn't true that we could stop the incidents by, and the research does show that they don't necessarily reduce, they might do initially, but they don't, in the longer term, actually reduce incidents of violence or aggression. I just think it's a hide into nothing, really. Sorry, I keep going on about problems.
No, not at all. I think it's obviously hard not to, and I really appreciate all of you trying to sort of condense what is the unanswered to what is a massive question into a relatively short space of time. But, you know, also there's so much in what all of you have said that I'd like to spend hours talking about just in its own right. But all of you have touched on kind of thinking about what safety actually means, safety for whom, safety, you know, sort of the illusion of safety that's often constructed with things like whether it's technology or whatever it is that sort of is widely considered to be guaranteeing safety. But when we interrogate that as we're doing now, it becomes very apparent that that's not the case at all. So yeah, there's a lot here.
Can I just say there's a comment from Rory in the chat, which I absolutely agree. The risk sort of measures, safeguarding processes are biased towards ensuring the safety of organisations, not people. I absolutely agree with that. That's such an important point. That is where the gaze is looking at protecting the organisation, protecting the staff, not at the safety of the patients. Yeah, sorry.
Yeah, no, not at all. I think it's a really important point, and whether it's about protecting organisations, whether it's about protecting police, the state, people who are working in sort of these places, I think that's something that can be seen sort of across a lot of different settings. I'm conscious that we're kind of running out of time, but the last thing that I wanted to put to the panel was a question about how, and so I appreciate a lot of you have touched on this already, but the last question that I wanted to ask is how might we collectively resist these practices? And sort of in answering this, where applicable, it would be interesting to hear sort of about some of the things that are already happening. I know that Hill talked a little bit about sort of engaging health workers in these conversations and things like that. So yeah, would be interesting to hear your thoughts on how, practically speaking, we resist these things. How would you be okay to start us off again?
Yeah. I kind of wanted to quickly just pick up on some of the discussions and things that you were saying, Alison, because I think
of course.
So often kind of reduction in number of incidents is kind of used as the sort of measure, and as sort of is viewed as like, right, that's definitely a success then. And that's one of the kind of things with Oxevision is that it was kind of saying that it was great because it reduces the number of incidents, but the problem with that is that it doesn't actually ask where that distress is going. And like, I think for me, often when I have self-harm, that doesn't necessarily mean that like sometimes, because that is for me an effective way of managing that distress, the kind of the fact that that hasn't happened isn't necessarily always kind of the best outcome. And I think it's kind of measuring those incidents and saying, oh, it's a success for the service, but it's not actually looking at what they're doing to kind of consider the distress that is driving the need to like self-harm and stuff. But sorry, that was just a tangent because my brain just works in that way. But I think in terms of resistance, one of the there's kind of lots of different ways of kind of whether it's sort of at an individual level or at a collective level, and sort of both kind of nationally and more in like local services. So I think like some of the stuff that we're doing as Stop Oxevision is kind of focused on sort of the wider picture and sort of looking at how surveillance technology is being used like across different trusts, but then we're also working with sort of more local groups who are challenging things in their own areas. I think one of the things that's always been quite significant for me is about like, and this is kind of again goes back to what you're saying, Alison, with about kind of understand like patients actually understanding our rights. And I think what I found is that there's a lot of things that happened to me many years ago when I was on mental health wards, which at the time I didn't even question because I had like such a sort of like low self-worth anyway, that I wasn't even aware that what was happening was kind of so clearly like in breach of my rights. And so I had, it's kind of lots of things only been years later that I've been able to think like, actually, that shouldn't have happened. And I think because of that, yeah, I think that kind of highlights how important it is for people to like support patients to know what their rights are as kind of resistance in that sense, so that people actually are aware that we deserve so much more. And I think it's something that we've heard from people about things like Oxevision, where it's been used and they've not really felt able to question it or not been able to question it. And it's kind of, they've sort of, you know, not necessarily know what their rights are and things. So it's only kind of afterwards that people kind of question it. And I think, yeah, it's sort of the importance of people being able to understand rights. But then obviously that's only goes so far when they're kind of not upheld, and, you know, we go through the processes of making complaints or expressing what our rights are, and that's then kind of not heard and challenged. So it, you know, it's important to know that it only goes so far. But I think for me that is something that feels important. Yeah.
No, thanks very much, Hal. I really appreciate what you shared there. Hill, would you like to take this one next?
Yeah. So I guess in terms of like collectively resisting these practices, I think medac's kind of all about its approach is that like we have like a systemic approach. So but at the same time, you know, that shouldn't feel like overwhelming, like we can't make a difference in the way we resist. And that's what we exist to support health workers to try to make change to those systems. And we encourage people to resist in whatever space they are, the mental health space or other areas of health or wherever they might work, or be service users. And yeah, like there have been kind of individual advocacy campaigns, but we just think that's less effective than structural change and overturning like policies in their entirety. So, I mean, I guess some of the issues I mentioned, the Patients Not Passports campaign is very active, very vibrant. Like it combines, yeah, like service users, patients with health workers and solidarity with those who've been charged. So there's like a new joiners meeting on the 17th of January. Details on the MedAct website if anyone's interested in that. Similarly, for our work around Prevent, including vulnerability support hubs, the way that approaches the campaign issue a bit differently. So we organize like alternative trainings on Prevent, because the official Prevent trainings are like mandatory for health workers, and they spread this idea, this kind of like this very racialized and spurious idea of extremism, and that you must report if you have like suspicions about people. And essentially, if you're a Muslim with sort of in mental distress, you're kind of like going to be very worried about that. So the alternative trainings are kind of to encourage health workers to resist, and kind of like a grassroots bottom-up approach to spreading that. And then like with regard to the criminalizing distress work, I mean, I think that the Stop Sim campaign like was really exemplary and really inspired us to kind of get involved and try to support the research and campaign work that they did. And I think we hope that like bringing the health worker voice to support the service user voice can be like potentially powerful in combining those two groups, like obviously acknowledging that there are ways in which there can be tension, because health certainly can be a space of like harm and violence, but we hope that there's ways that like we can work together to resist some of the most harmful surveillance and data sharing practices.
No, thanks very much, Hill. And I just want to pass over to Alison. I know that we're quite rapidly running out of time, but I'd like you to be able to also weigh on this before we have to wrap up.
I don't have a great deal to sort of add really to what people are saying, but I think it's I think collective organizing would be, I think we've had the heart sort of taken out of our collective organizing in recent years due to, you know, all the cuts in services to voluntary organizations and user groups. We've lost a lot of ground there. So I think NSUN has a great role to play really in bringing people together around these kind of themes and making these really important links with organizations like MedAct And Stop Oxevision, I had heard of Stop Oxevision, but not Medact. So I'm going to really look you up and find out more about you. So campaigning collectively has always been sort of such an important part of what we do. And I guess maybe we need to put all of these together in one, compassion, not criminalisation, somebody put in the chat. So, just a collective campaign that would bring people together would be a really, really good plan. Don't know how much we'll, managed, but the other thing I just wanted to mention, because I did put it in the chat, was advocacy. And advocacy, I used to be involved with advocacy projects at one point. Friends of mine were leading on advocacy projects in London, and they were a real good place for people to come together and find out their rights and understand how to challenge when things were not going so well. And that again we've lost that, but maybe we could, campaign to bring back advocacy in its original independent role. I'll stop there because we're nearly out of time.
Yeah, no, thank you very much, Alison. I really appreciate you all kind of grappling with such big questions in such a short space of time. And as I said, I would love to spend a lot more time talking about lots of different things that will come up here. Amy and Gabs, am I able to do a quick time check in terms of how much of it we have left, what we can realistically do in the next 5 minutes?
Trying to unmute. Yeah, so we have only got 5 minutes left and we do need to finish at 3. So I guess we could potentially have one quick question if anyone has got anything, and see if any of the panelists want to speak to it. So do feel free to put questions in the chat if you want to. But if not, we can wrap up a few minutes early if nobody has any questions. But yeah, sorry, we have quite tight timings today, so I have to be quite a strict timekeeper.
Okay, yeah, thank you, Amy. So I'll just give it a few seconds in case anyone has got a question that they'd like to pop in the chat or otherwise ask. I was wondering a bit about the engagement of health workers, that question. I know that that's something that's happened on the Patients Not Passports front with Medact. I was wondering whether Hat or Alison had any sort of experience sort of trying to engage health workers in sort of some of these conversations at all. And I know that may be quite a big question for the 4 minutes that we have, but just on the off chance.
There's somebody called Mick McEwen, some people might know, who's very interested in forming alliances with unions as well, and forming alliances to sort of challenge. He's a I think he's an academic, but he's an ex-nurse, I think. I could be going slightly offside here, but yeah, he was very interested in bringing together alliances with the unions, and that would be, I think, another potential collective approach.
Yeah, that's really interesting. Thank you very much, Alison.
Yeah, I think my experience of campaigns and things is that often, and I know that there are kind of health workers who kind of do things in the background or may approach sort of resisting practices more from kind of the inside, or kind of contacting their own work and things like that. But I think generally what we've found has been that it's very much kind of responsibility for us as survivors to be kind of raising these concerns and sort of doing the bulk of the campaigning, really, and often that it's kind of only later that the professionals sort of pipe up when it sort of feels safer and more convenient to be challenging things. Somebody, a kind of health worker, said to me after I'd kind of raised some concerns about something that he'd written, and I just sort of challenged some things, and he described it as kind of an act of kindness for me to have sort of brought that up, and it's really like stuck with me and gone round and round my head because it didn't feel right. And I think like the problem is that it's actually like feels more like an act of survival. Like, I mean, it's kind of that it feels that it falls to us as like patients and survivors because our lives literally depend on this, and we can't afford to not challenge things and not to resist things. So whilst health workers and staff often kind of worry about the, you know, if it could impact their jobs and things like that, and obviously, you know, I do understand that, but I think the thing is that for us as mad people, this is literally our lives depend on this. So there isn't the luxury of being silent about stuff. Yeah.
No, that makes a lot of sense. Thank you very much. Thank you. It's a really important perspective. So I think with that, unfortunately, I would really like to carry this on, but we are at 1 minute to 3. So I think all that's left for me to do is thank all of the panelists. Really appreciate all of your contributions, and I really appreciate everything that you've shared today, because these are not easy conversations to have. We've asked a lot of big questions in a short period of time, and yeah, we really appreciate the answers that you've given and the discussion that we've had. I'm sorry that we couldn't allow more time for questions, but also really appreciate everyone who's attended. And yeah, I hope that you've all got as much from this session as I have. So yeah, thank you very much, everybody.
Thanks so much.
Cool.
Thanks a lot.
Thank you. And yeah, we'll maybe see you all in the session later on this afternoon.
Take care. Bye.
Thank you, everyone. Bye.
Take care, everyone. Thank you.